topic today will be the use of the bhalla score system. Just a second. In the detection of pulmonary parenchymal changes in patients with cystic fibrosis detected on high-resolution CT. Cystic fibrosis caused by mutation, the cystic fibrosis transmembrane conducting regulatory gene is an inherited chronic progressive and fatal disease. It mainly involves the lungs and pancreas, but also the upper airways, liver, intestine, and reproductive organs. Deletion in the genes leads to the dehydration of the airway surface liquid layer, reduction in mucociliary clearance, and chronic bronchopulmonary infection in the lungs. High-resolution CT is well established and is the current gold standard method for monitoring lung anatomical changes in patients with cystic fibrosis. Facilitated evaluation that engages has longitudinal evaluations of patients and standardized comparison between, and therefore is useful both for the clinical and research areas. The bhalla score system, widely used particularly in pediatric and adult patients also with cystic fibrosis, is clinical and also physiological characteristics. The aim of this study is to detect the morphological changes, their distribution along the parenchyma due to the cystic fibrosis lung disease in relatively young patients, according to high-resolution CT findings, and to correlate the hereditary scores using the bhalla scoring system with clinical parameters. A total of 32 patients diagnosed with cystic fibrosis came to our University Clinical Pulmonology-Skopje to perform high-resolution CT for the first time. Clinical data, age, and application, deep throttles, and sputum cultures were obtained from our medical records. High-resolution CT was performed in 1:8 slice Philips incision scanner using 1 mm slices and high spatial algorithm for reconstruction, of course, using bhalla score system. Weight, height, and body mass index were also used for clinical evaluation. Deep throat and sputum cultures were evaluated for the presence of bacteria Pseudomonas aeruginosa. High-resolution CT was performed, as I already mentioned, on 1:8 slice. The scoring system proposed by bhalla collaborations and CT evaluated the following: severity of bronchiectasis, extent of bronchiectasis, peribronchial thickening, extent of mucus plugs, abscess or circulation, generalities of the bronchial division involved, number of valves, emphysema, and collapse or consolidation. The analysis was conducted on the selected group of 32 patients diagnosed with cystic fibrosis, encompasses variables such as age, gender, body mass index, and bhalla scoring parameters. As we can see from the graphic, that the gender distribution is more slightly presented in male with 69% according to female 31%. The average age of all patients is 22 years. The oldest patients is 44 years old, while the youngest is 11 years old. 47% of the patients belong to the age group from 10 to 19 years old, 11 from 20 to 22 years old, 5 patients from 30 to 39 years range, and 1 is from 40 to 49 years range. The average body mass index of all patients is 20.39. The average body mass index of patients by age group is 1991, 2040, and etc. Clinical parameters, as I already mentioned, that were obtained. Insufficiency pancreatitis present in 14 patients, which means 44% of all of them. Distribution across the age groups is also presented here on the graphic. There is a strong correlation we can see between the number of patients in each basket or age group and the presence of pancreatitis in the total number of patients. 88% of all patients exhibited at least one type of sputum. Predominant was Pseudomonas aeruginosa bacteria, whose presence was found in 44%, and methicillin-resistant Staphylococcus aureus bacteria with the same representation of 47%. Less prevalent occurrences of Aspergillosis fumigatus is 9%, Aspergillosis flavus 3%, Escherichia coli 3%, and Staphylococcus aureus 3%. As a basis for calculating the percentages, the total number of patients is taken into an account. Dual bacterial diversity was present and detected in 8 patients, while 19 manifested a single bacterial type. No bacterial presence was identified in 5 patients. The bhalla scoring system serves as a methodology for assessing computer tomography findings. The score considers 9 specific parameters, as I already mentioned in the previous and the first slides. Scores from 0 to 3 on the bhalla score system were assigned to each of the first 7 categories. And while from 0 to 2 are assigned for the last 2 categories. The total score may have a maximum value of 25 and was calculated by adding individual scores for each item. The total points were then subtracted from 25 to obtain the bhalla score. The maximum points that can be obtained in a bhalla score system is 22, prior to subtracting from 25. The total range for the bhalla score is from 3 to 25, where a lower score indicates more severe high-resolution CT findings. This score was subdivided into mild, moderate, and severe. Mild is from 16 to 25 score, moderate 9 to 15, and severe 3 from 8 to 8. The average bhalla score from all patients in this study is 18.31, which belongs to the mild range in our case and in our study. 78% of the patients belong to the mild range, 6 patients or 19% of all belong to the moderate range, and 1 belong to the severe bhalla score range. No significant correlation was found between the age and bhalla scores, age and body mass index, and body mass index and bhalla scores. Significant correlations were found between peribronchial thickening and bhalla score, extent of the bronchiectasis and bhalla score, and generalities of the bronchial division involved and bhalla score. Below we will highlight the most significant results of bhalla scoring. 66% of all have mild, like subtly greater than the adjacent vowels severity of bronchiectasis. 53% of all have mild peribronchial thickening. 41% of all have from 1 to 5 extent of the bronchiectasis. 53% of all have from 1 to 5 extent of mucus plugs. Absence or abscesses of circulations is confirmed as absent for 81% of all patients. Generalities of the bronchial division involved are 28% over the 5th generation and 38% over the 5th generation. Bubbles are absent for 84% of patients. Emphysema is absent in 97% of patients. Collapse or consolidation is absent in 17% of our patients. Here on this slide, we can see high-resolution CT of both lungs, where we can see mild bronchiectatic changes in a patient with cystic fibrosis with bilateral mucus plugs and 3 in-bed characteristic pattern reflecting exudative small airways involvement, which is also widespread and nodular. I don't know if you can see where I'm showing that. Yeah. On this picture, we can also see a high-resolution CT scan through the upper lobes of an individual with also cystic fibrosis showing cylindrical bronchiectasis and bronchial wall thickening. On this slide and on this image, we can see peribronchial thickening in lower lobes, which is more severe comparing in the previous images, and also full fit with mucus plugs. It is also bilateral paracardial. On this image, we can see an early stage of cystic fibrosis detected on high-resolution CT. There are also initial bronchiectasis and a little peribronchial thickening, but there is still no mucus plugs. The main cause of mortality in patients with cystic fibrosis is lung disease. For this reason, it is critical to improve pulmonary diagnosis in patients to better predict adverse events and monitor therapies. Currently, different variables, including high-resolution CT scores, sputum cultures, and clinical examinations, are used to assess pulmonary changes in patients with cystic fibrosis. The rationale for performing high-resolution CT in patients with cystic fibrosis is to obtain additional information with prognostic significance that should be used to modify clinical approach and treatment. For this purpose, standardization of the radiological evaluation through a scoring system is crucial to obtain correlation with clinical outcome and for reproducibility. In this study, no significant correlation was found, as I already mentioned, between the age and the bhalla score, age and body mass index, and body mass index and bhalla scores. But significant correlations were found between peribronchial thickening and bhalla score, extent of bronchiectasis and bhalla score, and generalities of the bronchial division involved in bhalla score. This is the fact because of the fact that the main high-resolution CT findings to establish cystic fibrosis diagnosis are bronchial wall and or peribronchial interstitial thickening, especially when it's early in the disease. Mucus plugging is of particular importance as it is thought to precede infective exacerbation, and thus identification of such plugging may be used to trigger changes in therapy. In our case, 53% of all patients have from 1 to 5 extent of mucus plugs, and dual bacterial presence was identified in 10 patients, while 12 patients manifested a single bacterial type. Pseudomonas aeruginosa infections is considered a risk factor for the development of bronchiectasis in children with cystic fibrosis. In our study, 44% of all patients had Pseudomonas aeruginosa in their sputum. Acute recurrent pancreatitis and chronic pancreatitis are described as relatively rare manifestation of cystic fibrosis. They have been associated with minimal or mild respiratory disease and pancreatic insufficiency. In our case, pancreatic insufficiency was found in 40 patients, which means it's 44%. It's not low number of patients in this case. In 1991, two independent publications by Nathanson and bhalla collaborations proposed two distinct scoring systems for the evaluation of cystic fibrosis lung disease in children and in adults. In a study comprising cystic patients aged under 12 years, Marshall et al. Compared these two scoring systems and showed that the bhalla method was superior to the Nathanson method in young patients. And now, given the fact that we're talking about the relatively young patients, our most significant results of bhalla score are that 66% of all patients have mild severity of bronchiectasis, 53% of all have mild peribronchial thickening, and 41% of all have from 1 to 5 extent of the bronchiectasis. Mucus plugs were found in 53%. In our study, abscess recirculation, bubbles, emphysema, collapse, consolidation were found in minority of the patients, and the average bhalla score from all patients is 18.31, which belongs to the mild range, but slightly approaching to moderate range. One of the limitations of this study is the small number of patients. A prospective and larger study is needed to confirm these results and would help in further understanding cystic fibrosis progression and disease management. Another limitation of the study is the relatively small number of different clinical parameters measured. For instance, the number of exacerbations were not evaluated in this study. Future studies are needed to assess the relationships between these variables. This study showed the usefulness of chest high-resolution CT bhalla scoring system in the pulmonary evaluation of young patients with cystic fibrosis. High-resolution computed tomography is well established and is the current gold standard method for monitoring lung anatomical changes in patients with cystic fibrosis. To facilitate evaluation and comparison of quantitative data, investigators have developed quantitative scoring system based on computed tomography findings. bhalla chest high-resolution CT scoring system is useful for pulmonary evaluation of children with cystic fibrosis. Thank you very much for your attention.